All right, so today we'll talk about communication in physical therapy. Um, and we'll also talk about soap notes. Who printed out the PowerPoints? So were you a little overwhelmed with how long it was? All right, it's going to, you wrote them out? Really? Wow. Well, good for you. Hey, I mean, if you want to talk about preview reps, actually, can you teach class today? I'm a little tired. You want to do that? No. Um, So great preview reps, right? So it will go a lot faster. A lot of it's just quick practice things, so it's going to go a lot faster than 40 or so slides. So let's get into it. So there's our learning objectives. So communication overall, I will say when I talk to seasoned clinicians, the more we stop talking about the anatomy, the injury, the disease, the exercise, the treatments, and the more we talk about how do we talk to our patients, how do we motivate them, and how do we actually get our patients to do their home exercise program, right? And it's so much more about communication and connection than the actual like problem that they've got. Um, and I bet you it's not any different than teaching, right? It's not about the subject you're teaching. It's about connecting to the student and getting them to actually open up their book or care about this or. And I bet you that's the same for most of our careers is at a certain point, the thing we're doing is easy and it's just the people we're talking to is the hard part. I bet you, I mean, with your job, even with baking, is the baking hard? How about dealing with customers? Yeah, right. That's not because that's the hard part for you, right? So communication is so important, and making sure you're communicating in a way that one is professional, but two helps our patient. And there's a we could spend years talking about just communication and adding layers to it. So I will say it's one of my favorite things to talk about, favorite things to learn about, and I think it's something that I wish we would spend more time on the technical aspects of communication in addition to all the other technical stuff that we have to learn. Um, so a process communication is process in which information is exchanged between individuals, common system of symbols, signs, behavior, um, and then six primary types of communication: verbal, nonverbal, reading, writing, listening, and electronic is a newer version. So what is it? Verbal, the words we say, the tone in which we say it, the speed of our message, all of that is part of this process. Nonverbal, crucial for us in the healthcare world to have appropriate nonverbal and body language, nonverbal facial and body language. Um, our textbook has some good pictures where if one practitioner is sitting there like this, just this crossed armed alone, is less inviting than if somebody has their hands by their laps or more inviting. Um, or facial expressions have a lot to say before our words ever do. There are different positions we can put our patient on to apply treatments to, whether it's my hands or maybe a hot pack or anything else like that. Um, Anytime I'm doing just something to my patient, I am trying to see their face as I do it because their face will alert me to discomfort, being nervous, feeling good, then they're way faster than their words ever could. And I think my wife does this where I'll walk into the house and she'll look at me and she'll say, "What's wrong?" Did anybody else get that from their spouses or people that live with them? Um, and it's like, how did you know? Well, you can just see it on you, and maybe you know that from other people too. Like you can just see. You ever maybe the day before you get sick, you get people asking you like, "You all right?" And you go like, "Yeah, why? What do you just look a little off?" And then the next day you're sick and like, I can't believe they could tell. I didn't even know I was sick. So that's all part of our nonverbal communication. And our nonverbal communication as we talk with our patients is really powerful. Um, Other is reading. So reading for us could also include professional literature, reading journals, reading research articles, medical records. We're going to be reading our patients' medical records. It could be reading from other providers what they saw with the patient and what they think. Written, we're going to have written instructions to our patient and family, also to other healthcare workers. Listening is a powerful skill, and it is a skill. And what we mean by listening is active listening. So most of you right now are passive with your listening. You're there. Maybe you jot down a note. Maybe you start thinking about, oh gosh, Josh started talking about pie. And you know what kinds of pies I like? Who'd started doing that? Now you are, right? Where active listening is an engaged process, and that can really be helped with what's called restatements and clarification questions. So restatements are, all right, I heard you say your knees started hurting when you went mountain climbing. Yes. Oh, no, it started hurting before then, and then I went mountain climbing and it hurt even worse. Oh, okay, all right. Tell me about before then, right? So what I did there was I restated, the patient said something else, and then I asked a clarifying question. Clarifying questions can be really important because our language can't always be vague, and we always want to make sure we're actually understanding what our patients are talking about. Anybody not from Rhode Island? Is everybody from Rhode Island? You are. Where do you guys live now? Or where did you live other than Rhode Island? New York, New York, Wisconsin. All right. So in Rhode Island, when I treat patients, and my patient says, it starts to hurt when I drive for a long time. If you're from Rhode Island, what does a long time mean? Yeah, probably about 20 minutes for most of us. Yeah. If you are from South County, Rhode Island, do you guys, anybody from South County, Rhode Island? Do you know the landmark? Because I know you're working down there. Do you know the landmark that everybody thinks you're crazy for going past? The towers? Yeah, the tower. Oh, that's north of the towers. So, I had one patient when I was working in Middletown. I had one patient, he was 94 at the time, that never left foot off of Aquidneck Island. His entire life was spent between Newport, Middletown, and Portsmouth. And I looked at him and I said, well, you can't now. Like, you're 94. Like, you got to see this through. Like, you got to stay. But yeah, 20 minutes is a long time. Now, 20 minutes in Wisconsin, what do you think?
We actually have a joke where it's why would you fly when it's only 6 hours?
Yeah. Why would you fly? That's perfect. Yeah. And in the Midwest, there's a ton of that. Big open land. Let's just go for a drive. Yeah. I know my brother lives in Nashville, and I talk to a lot of people, and oh, you're from around here? And the answer is always like, yes, but then they end up being like, well, 4 hours away. And it's like, but that's not from around. Like, oh, no, but it is from around. Like, we count it. All right, fine. From around here in Rhode Island is, no, I live on Cranston East, not Cranston West. Like, so that's a clarifying question. That can be really important. My patients say they exercise every day. Okay. What do you mean by that? My patients that exercise every day tell me that because of the diuretic they're on, they have to go pee 5 times a day. And that's their exercise, walking to the bathroom. Okay, well, that's good that you're doing that because we don't want to stay here and have to go, right? But that's not really exercise. We're going to do something a little different with exercise. So asking those clarifying questions is making sure we're taking in the full message and making sure there's nothing vague between us. Really important. And then electronic communication. One, we have electronic documentation we'll talk about briefly. We also have electronic messaging. Not only, I had a patient text me last night. So I have electronic communication with my patients in the form of text messages. There's also electronic communication similar to text messages within some EMR, so within some electronic record keeping. So I could send a secure text message to someone that works in the hospital if I wanted to. So we'll talk about some of the good and bad of that later too. If you talk to professors that teach physical therapy, all of them will tell you it's way easier to teach you physical therapy than it is to how to talk to your patients. Because the communication has to do, like, we have to take pieces of our own culture, and our experiences and attitudes and values, and it greatly varies between people, and it can be really hard to teach how do we communicate. And actually, if we have a student fail a clinical, 9 times out of 10, it's because of communication breakdown between their clinical instructors and the student, and not the actual skills of the PTA, of like, did you do the right exercise or the right hands-on treatment? And it's always communication. 9 times out of 10 is communication based. So it's a really tough skill to learn and get better at. But for us, we have a really tough job in healthcare. We have a really tough job in comparison to other people. We have to get our people to exercise. Do our patients want to exercise? Most of them. No, no. Who's a tech here? Who has tech experience? Your patients. Do they like exercise or no? No, no, no. What percentage come in and be like, oh, I'm ready to go. I can't wait to exercise. I got to get back to running or sports or coaching or whatever it might be. What percentage of patients do you think that is? Younger, definitely. Do we have younger athletes that also don't want to exercise with us though? Yeah. So my gut was telling me 20. So I think somewhere between 20, 30%, depending on the week really. But yeah, not a lot of our patients actually want to be our patients. So we have a really tough job to do. Way different than the surgeon. Now, surgeons got their own challenges, right? But the patient gets to be asleep during that time. The patient's not up saying, no, don't cut there. I don't want you to cut there. No, move that other organ the other way. I only want, blue stitches. I don't want those other stitches, right? But what are they doing when there are patients and all of that kind of stuff, right? So being able to communicate, being able to get our patients on board with what we want to do and not necessarily something they're excited about, we have a really tough job. We also have to make sure a patient can follow our directions. We also have to get them making their own decisions, but we have to get them making their own decisions in a way that's going to benefit them. And that's really tough. That's a sales. Anybody work sales? The sales thing. Like, how do I get this person to feel good about spending this money? Yeah. Personal training, that's sales. And I guarantee if you went in, and maybe, how long have you been doing training for? So you might have been doing this initially. How good were you at sales initially when you were doing personal training? Sucked at it. Because and I was in sales in a handful of different roles, and I always sucked at it. Until I realized actually I am better at sales if I'm stop being so stupid. Terrible way to sell personal training is to meet someone and say, well, if you sign up for this package, I could start with you tomorrow and it's only this amount of dollars, and that person's never going to buy from us, right? But if we start talking to them and saying like, oh yeah, I'm a trainer, and they start saying, oh, I'd love to do this. Oh yeah, why? Well, because I got this wedding coming up, and my high school reunion shortly after that, and I'd love to just look a little bit. I tried on my suit for the first time in 3 years, and I can't even button it. And you'd be like, wow, that's crazy. And maybe you just say, if you want to come by, I could show you the place. If you're interested, then we could start doing it. Now that's a sale, right? Now we're listening to our patient. We're seeing what their needs and wants are. We're telling them how we can solve that problem. We're bringing them along the way, right? Way different. And I bet you your process from 5 years ago to now Yeah, yeah, yeah. And if
Getting them in, like,
get your foot in the door, see the gym, see if you could see another client that's happy walking out, like the sale's already done. I don't have to tell you, right? Yes, there's a lot of that. So getting the patient to make those decisions that's in their best interest, but we want them to make that decision is a little bit of a sales process. But we have to make sure it is their decision because that is informed consent. Being able to motivate patient and being able to build rapport with our patients is really important. So this rapport building is stuff that I continue to try to improve upon. One of these methods is an interesting thing to think of. So first of all, cultural norms is really important with communication, right? I think, and we'll talk about generations down the later in this too. My father's and grandfather's generation demanded that men look each other in the eye. Like that is a cultural norm from more traditional. I think it still happened, but more traditional. Like you have to shake someone's hand, firm handshake, look them in the eye. In some cultures, looking at you in the eye is culturally unacceptable, right? It is that is aggressive, and that is so having cultural norms that's part of that communication that's really important. Um, there's other cultural rituals, especially in healthcare, dress code. The variety of settings have variety of different dress codes, but looking professional, I think, is really important. Um, I I was talking with one of my uh, owners of a clinic, and they told me they fired their attorney because they dressed down on Fridays, and I was thinking like you probably weren't that happy to be with the guy anyway, and you're just kind of saying like I'm fed with him, but he said I'm paying this guy 700 freaking bucks an hour and he's wearing tattered jeans on Fridays. No, he's gonna wear a suit when I'm paying his seven. Like, got a point. He's also of a little older generation, but hey, you got a point, right? So when we are the healthcare provider, we want to make sure our dress code is appropriate for that. In some ways, that's really good. In other ways, it can cause a barrier. We'll discuss that. Verbal rapport, having similar descriptive phrases or conversational context is important. When I lived in Hawaii, I was having this is I made a lot of cultural and verbal errors when I was living in Hawaii. Um, I was having my patient do an exercise where they're doing this with their arm, shoulder abduction, but I want to do it both at the same time. And I said, yeah, just like you do a snow angel. And they looked at me and they said, Josh, what's a snow angel? And I said, it's when. Oh yeah, you live in Hawaii, you don't know what snow is. All right. When it snows, you lay down in the snow and you flap your arms and legs back. And they looked at me like, why the F would you possibly do that? Well, when you get up, if you don't step in it, and everybody always steps in it, but if you leave it, it looks like an angel. And you go, that's what you guys do for fun? That's what the big fun of snow is? You get to lay down in it? So that was, I was not building cultural or verbal rapport with my patients when I did that. So there's also behavioral rapport. This is a really interesting technique where we want to mirror posture and movements to create synchrony. And if you ever watch someone, if you're in retail, if you're the manager, when somebody says, I want to talk to your manager, the really good people dealing with customer complaints do a phenomenal job with mirroring and like empathizing and having similar body language to that person, where it gets it develops a relationship where now there's less hostility. This kind of like, and that happened, I can't believe that happened, and the register over there, like you're mirroring the person, and you're getting them, like all of a sudden you're a team now and not a confrontation. So I don't know if anybody's seen that or participated in any of that. Yeah, when have you seen it or done it? Do you think to yourself like I've got to mirror this person, or you do? Tell me more. Tell me more.
Well, it's like maybe, they're a little bit more quiet, a little bit more quiet, more.
Is this as your aid position? Okay. Yeah. Gotcha. Do you ever have to talk about billing with people? How happy are they? Never ever happy. Absolutely, absolutely, yeah. Being just as frustrated and flabbergasted that they denied or the deductible they didn't know about, like, yeah, and what do you feel how that takes away the conflict between you and that person? Amazing, right? Um, so I think that mirroring and posturing of posture and movement and tone and all of that like is really powerful. And if anybody's been able to do like seek opportunities to do that and see what it feels like. Maybe when you're talking to your next angry customer, that'll help you. But I think the example that we have is our behavior when talking to toddlers versus adults. What is everybody's voice and everybody's posture when we're talking to toddlers? What changes do we make? Yeah.
Bring it down.
We mirror them, right? First of all, we get low, we get eye to eye. Maybe our voices elevate. We're more cheerful. We think the everything is the coolest thing in the world. Like the Jack in the Box came out. I can't believe. Like, yeah, we mirror them, and that develops more synchrony too. So, I think sometimes we do that naturally. If my daughter was in here 2.5, at first she'd be super shy, and everybody would just kind of start doing this and maybe just a little peek, right? But then eventually she would be more animated and we'd become more animated too. I think we naturally do some of that, but it's when we're met with confrontation, I think it's a really powerful tool that seek opportunities for that and tell me what you think. Anyway, so cultural differences will happen. Patients are going to have a variety of ethnicities, generations, religious beliefs, sexual orientations, socioeconomic backgrounds, and culture has to do with all of that and more. Um, and it's important for us to recognize our own biases to then be able to better communicate with our patient. And when we can recognize our own biases, we can begin to defeat them. I told you guys what my bias was, right? What was my bias? Do you remember why and why? I guess trailer parks. Do you guys remember why? Maybe I didn't tell you guys. All right, so my bias is trailer park neighborhoods, and I dig some deep digging in why because it never used to be that way. So the reason is so here's my bias. I punch in the address to a new patient. It's my GPS. As soon as I turn down their road and it's a trailer park, I immediately say like, "Oh God, this thing." Now I will tell you, I can think of some of my favorite patients have lived in trailer parks, and they're just great, great people, and the kind of people that if I happen to be in their neighborhood, I'm gonna swing in to knock on their door just to say hi because they're just great people, and I think about them. But here's why early in my home care career, I had a patient in Exeter. Now I grew up in West Greenwich, Exeter, West Greenwich. This is basically one town. Pulled in, I was early, so I stopped. I'm sitting in the car, I'm reviewing some notes, and I get a knock on my door with someone from the neighborhood and a chainsaw in his hand and says, "What the F are you doing around here? Why are you here?" Now, meanwhile, what does HIPAA say that I can tell him? Nothing. I'm here to see someone. Yeah, I'm expecting them. I'm this house right here. I'm gonna go. Why are you here? I can't really tell you, man, but that chainsaw, that's a nice chainsaw. You guys out of Husqvarna? Is that what you got there, right? So that, it, yeah, and then as soon as I pulled into a trailer park after that, I had that negative feeling. I didn't know where it was from until I started telling that story, and I was like, "Gosh, I can't believe that's what it is." But yeah, so that negative feeling though still sits inside of me. If I had a patient tomorrow and I pulled into their neighborhood, I would immediately have that negative feeling, that bias. Does that bias have anything to do with the person I'm seeing? No. So I have to make sure I check that bias to make sure that no, you're here, everything's fine, no chainsaws. Okay, good. Like, you're gonna do your job. But it's funny how biases can come from anywhere. I mean, that was such a silly, and looking back on it, humorous event. But at the time, it wasn't really funny to be staring down the barrel of a chainsaw. Um, so, but biases can come from any places. Sometimes it's ingrained in us by other societal norms, cultures, um, you know, older generations biases coming in to seep into us still happens. So it's really important for us to really understand ourselves. Um, Applying the professional value of altruism, putting the patient's welfare above or others above our own. We have to, when we see an incongruency of values, it is okay. And as long as we're treating the patient to the best of our ability, you don't have to like them, you don't have to respect them, but you have to treat them to the best of your ability. Um, I read a story. This is gosh, it's 7 or 8 years ago now. I don't know if anybody remembers. In New York City, a terrorist rented a U-Haul van and drove through a crowd of people. I don't know if you guys remember that. So that person later got into a car accident, broken leg, needed surgery, and then needed physical therapy after. Anybody want to be that terrorist who killed 3 people? Anybody want to be the PT or PTA for them? No, nobody wants to be that person, right? Their value set is not something I can comprehend whatsoever. But our professional duty of altruism says put the patient's interest above your own. You're not going to change this person's opinion. You're not going to fix the rest of them. Your job is to fix the leg, get them walking with crutches so they can move on to the next place that they will go down. And what if you can't? What if you say, I can't look at the guy, I cannot do this. What's your next step? Yeah, go to your supervisors, talk to the supervising PT, seeing if there's something else that we can do about this. Yeah. So it's not fun to think of that stuff, but like I said, I mean, until I did some of my own deep digging, if I didn't uncover the source of my negative feelings when I come down trailer parks, all the people that live in trailer parks would get inferior treatment because I had that bad feeling inside of me, and that can crop up in unique ways and unexpected ways sometimes. So we can develop our cultural proficiency. There's a few different terms for it. This is a spectrum. Cultural destructiveness, that's dehumanizing, that's saying anybody with, from that region, with that religion, from that, orientation, it doesn't matter. That person is bad, right? So that's dehumanizing. I wouldn't expect any of us, none of us would be in this room if we actually, that's a pretty extreme part of the spectrum. Patience, now, on the other hand, can be very, yes, very, yep. Then we have cultural incapacity, unable to work with patients from different cultures effectively. Cultural blindness. This is neutral. Everybody's the same. All right, that's not. At least we're not going out of our way to harm, but that's also not celebrating differences and being appreciative too. Competence acknowledges differences, weaknesses, and acknowledges and are acknowledged and alternatives sought. Cultural competences, differences are accepted and respected. And we can adapt our services depending on that knowledge. And then cultural proficiency, highly regarded. So I'll tell you some ways that I've had to move along the spectrum. I had one patient, I was really busy, and he was of Muslim faith and he had to pray at specific times of the day. Now, I don't recall off the top of my head what those times were, but I got to have a conversation with him, and I would say like the only times that I have is 10 a.m. And again, my pre-competence at this point is I know there's my weakness in this topic, and I need to seek more. But I was able to sit with them and say, okay, what times can't you be here? Okay, how about this time? And I'd be able to work with him around that cultural barrier that we had. So that's how I had to adapt because of culture. But there are others that we have to adapt our services, especially with our patients' biases. I can work on my own, and my professional values dictate a lot of what I have to do. I can't control my patients' biases. So maybe I need to separate other people. Maybe this person's not allowed at this time of day. So it,
Like one over here is another one, and then they're like going at it with each other.
when do you see that? What are they going at each other about?
It's usually Trump and Biden.
That's a yeah.
good way to go.
Yeah, that's a good way to be entertained for the next 40 minutes. Whisper to one of them, yeah, and he thinks Trump's guilty as sin, and the other one, he thinks Biden is incredibly competent. Whatever, I don't know what it's. So yeah, definitely, and you know what? Hey, that's part of the culture, right? That. So I'll tell you this other story. I did not have this patient. One of my colleagues, the female colleague, had this female patient. They recently moved from a country in the Middle East. I don't know which country because I was never allowed to talk to the woman because I was a man. She could only talk to females. She had to be in a private treatment room, not in the open gym where males were present. We can accommodate those things. And then here's the one that always when the therapist was talking to her about her ongoing neck pain and she's doing really good, but one of those like, all right, do you need doing the reevaluations, do you need more physical therapy or not? She said, I don't know. I'll have to go home and ask my husband. Because he's the one that has to make that decision. I can't make that decision. Now, I see some of the faces of some of the women in here. What do you guys think about that? Like, what the heck are you talking? Oh, you make that. It's your neck, right? But what do we when we bring our culture of perhaps no man's gonna right? What are we doing on this spectrum? We're not appreciating and understanding that culture, right? And she didn't want to be forced to make the decision. She was happy with her husband making the decision for her. That's because that's her culture, right? So being able to understand that difference and appreciate it, way more important than saying like, let me give you a little history of what women could do in America here. Now that you're here, why don't we, here's some pamphlets on, I don't know.
What you do in this situation? Like, I had one lady doing some rows, and she's just talking about how like everyone in the army hates each other. And she like hates Americans and that. And she asked me my tattoo is, and it's where I got deployed to. So I was like, that's where I get deployed to. And then she goes, oh man, that's for a different like person. And like, this hasn't been going in class.
Yeah. So the question was like, when our patients have a bias against us, how do we handle that? And you've got a perfect example of your patient hating everybody in the military, and you were in the military and have a tattoo about it. She probably hated your tattoo and not knowing what it was. So,
I think she hated me.
yeah, there's a lot of reasons not to like you. Our job is always to do the best interest of the patient. And the patient doesn't have to like me for me to do my job. I don't have to like the patient for me to do my job. But I also don't think we have to shield ourselves from our patients either. I had one patient, one therapist work with me, and she was working just per diem, just a handful of patients here and there. And she said one day, like, she had this like moment of crisis of like, Josh, I stopped hiding that I was gay and married to a woman. She was a woman, right? So, I stopped telling my patients, my partner, I call her my wife because she is my wife. And I was like, okay. And she was like, but if you have any complaint, I just want you to know I'm not going to hide that anymore. I said, great. I didn't know that was a thing. I didn't know that was like an internal crisis you were going through. Like, I love you. I think you're a great therapist. If any patient has a problem with you, they're really missing out on a great therapist, and we'll find someone else for them. But you don't have to hide who you are just to protect the patient. But if you don't like that person, if you thought everybody in the so let's reverse the roles. If you thought everybody in the military was a baby killer and your patient's in the military, what's your job? To treat the patient as best you possibly can, to squash those feelings because you have a job to do. And if you can't squash those feelings, your next best thing is to find them someone who can treat them to the best of their ability. But if you are the world's expert in this condition that they have, you should find a way. But I don't think, this culture, this altruism, professional value, right? Putting our patient's interest above ours does not mean you have to accept racism, bigotry, hate. Like you do not have to accept any of that. But we do have to work in the best interest of our patients. That can be a weird line to fit in. You can tell someone I don't like those kind of jokes. You can say I don't want that, right? So you can protect yourself. You say, hey, listen, I'm gonna let that one slide. If you do that again, I can't be your therapist. You can definitely do that. You can stick up for yourself. I'm not saying you should just accept that kind of behavior, but we have to balance it with the professional value of altruism. Does that make some sense? And it's so contextual into what that is. I can't tell you. I can't tell you what the situation is and what kind of decisions you'll be able to make when you are a professional. Anybody ever been a waiter or waitress, bartender? How do you ever have customers that you just can't effing stand? What do you spit in their food? Don't tell me if you do. No, but the answer is no, right? One, because you're good people. Do you just do you give them crappy service? What do? Treat them as best as you possibly can within your role. And you know what? They're going to be jerks tomorrow too. And you'll just have to do your job you're not going to sit and say, hey guys, great to see you. You're just going to say, what do you want today? And you're going to stiff me on the tip no matter what I do. So I'll get you out of here as fast as possible. Right. So yeah, I think this topic is really tough because we need so many context to it. Yeah, Janae.
Will like a patient will be upset with a nurse, and like by the time you go in the room with the patient, it's all solved already.
Yeah.
So they cuss you out.
Yeah.
So it's really like, if the patient is in the right state of mind, you don't have. So they
Yeah.
They'll apologize. I went through that, but I'm not, talking to these guys.
Right. Yeah.
And they're like, oh, I'm sorry, honey, like, I apologize for doing that, and it's just, and then it'll go on.
Absolutely.
Whatever they don't wanna do.
Yeah. I think most people are going to, when we say in a strong but not aggressive way, like that's unacceptable. I'm not the one that pissed you off, or who cares if I'm just here to help you kind of a conversation. Most people are reasonable and will adjust. And the ones that aren't probably aren't going to come back tomorrow anyway. But anyway, it's a complicated, tough topic to talk about. But it's really important for us because we treat patients in every single walk of life. I've had patients like many different cultures, many different religious backgrounds, political background. I mean, I go into plenty of houses that have 12 different yard signs for Trump, and handful for Biden, and I've my youngest patient was 3 years old. My oldest patient has been 103. Like there's we treat every single walk of life, every single um on Wednesday, I saw 3 people. One person was in as run down of a house that you could imagine, just because they're socioeconomically, they can't fix the floors, so we'll put plywood down. And then the other house I was in was a $4 million house. So, you know, the spectrum of people I get to treat is awesome, and I love being able to treat it. So, being able to understand the differences in backgrounds is really, really important. So some specific ways we may have to adjust our communication. Number one, for people with low health literacy. Approximately 80 million Americans have limitations in health literacy. So 80 million, what's the US population roughly? Right around 350-ish million. So that's a good percentage that are going to be very low health literacy, not understand basic medical instructions. If we're scheduled for surgery, what do they tell us to eat and drink? When do they tell us to not eat or drink? Do they say 12? You see her 12 hours before? So most of my patients get instructions, don't eat anything past 6 o'clock. Don't drink anything past 8. That's usually what my patients' instructions are. My patients get told that whether their procedure is at 8 a.m. or 3 p.m. And I think the more accurate answer is no eating 12 hours and no drinking 8 hours, right? Something along those lines. Whatever, I don't know the exact parameters, but which one is easier to understand? If don't eat past 6, right? That's easier to understand and comply with than don't eat before 12 hours before surgery. Well, one, they got to know what time surgery is. 2, they got to start doing the math of it, and for some people, that is really tough to figure out. Especially some medical. I know when I document my medical stuff, the time gets switched to military time, so that the time I saw my patient was at 1500. Where if I tell them don't eat, if their surgery scheduled for 1500, I say don't eat like that. That's a really tough thing. If you're not used to that, that's a weird thing to figure out. So that's because of health literacy. So what we can do is making sure asking for confirmation of understanding is really important for those people. Asking questions. We ask patients to the patient. What do you think I told you for due tomorrow? If you have kids, this is also a good tool. Like, and what do you think I said about brushing your teeth? Like, no, it's not what I said at all. Well, let's come here. Let's go show you what we're talking about. But potentially video or picture demonstrations can be helpful as well. Most of my patients, even my older patients, I shouldn't say most, but a good amount have smartphones. I stopped drawing or printing out pictures of exercises. I take a video of the patient doing an exercise and I say, there you go, there's your homework. Watch this video and do this now. I found that's been way better than still pictures and drawings or anything like that. No, this is you doing the exercise. I find that to be really helpful. Generational differences will vary between more traditional, using sir and ma'am as how to address people, versus the different younger generations don't expect that level of formal communication. My grandfather, he lived till he was 98, passed away about 10 years ago. An amazing guy, but he would wear slacks and loafers to go get a cup of button-down shirt. What I wear, he would not wear this pullover. But what I wear to teach is what he would wear to go to Dunkin' Donuts. Button up shirt, slacks, loafers, ready to go to Dunkin' Donuts, get a cup of coffee and a blueberry muffin. To go to the doc's office, he would polish his shoes and wear a sport jacket. And most of the time, he would wear a tie. But that's my grandfather's generation. Like, you wouldn't wear sweatpants out of the house. You like, no, the first thing you do when you wake up is you shave and you put on your slacks. That's doesn't matter what you're doing that day. If you're gonna sit on the couch, you're gonna wear slacks as you do it, right? And I mean, I've got plenty of patients in the older generation. I mean, that's in home care, that's mostly what I have, and I am way more formal with them. Versus our younger crowds, we get to communicate a lot differently. And the use of technology and tech, like I told you, I have one patient, she texted, she's 60, so she's one of the youngest patients I have. She texted me last night. Yeah, no problem. Versus in that expensive house I was telling you about, the woman is close to 80. I don't know exactly how old she is. She's terrible at texting. She texted me initially, and then I quickly realized, like, she sucks at texting. I'm just gonna call her. Like, she doesn't. She's getting lost here. So, just use of technology to communicate is something. I have plenty of patients that hate when they get the automatic text messages to remind them of doctor's appointments, and like that irritates them. Like, why are they? How do I get that? Like, so, you know, adjusting our communication for across generations can be important. We are definitely going to have patients with visual and auditory impairments, so visual, unable to see. Increased use of auditory verbal cues, announcing yourself when entering the room, increasing fonts of pictures or writing, and maybe using Braille. That can all be important, but definitely the increase the font initially. Auditory, making sure patient has clear view of your face and lips. So making sure, so I talked about earlier how I like to see my patient's face because of their nonverbal communication. Now, these people with auditory hearing problems, they need to see our face for all communication because they're going to be reading lips. And if we slow our speech rate, that's going to help improve their ability to read lips too. Light touch on shoulders to gain attention is also another tip that we can have for that. I will also say, talk about my grandfather a lot. It's great to think of him. My grandfather was completely deaf without his hearing aids. And he got really nice hearing aids that are like really small. He couldn't see them. There was plenty of times I would have a conversation with my grandfather. A full conversation, 20 minutes of me learning from, you know, the man who knows everything, the guy who's seen it all, like just the 25 minutes in, you look, you're not wearing your hearing aids? No. Have you heard a single word? No. But the entire conversation we had was, hey, Grandpa, I gotta talk to you. Yeah. I'm dating this girl and I just don't know. And she, like he's just pulling my leg, like I thought we were having a conversation. I pulled my heart to you, Grandpa. You're up in hearing aids in. All right. So I gotta say, and some patients with auditory impairments like can trick us into thinking. I've got plenty of patients that still do that. So anyway, LGBTQA as well, making sure we try to use correct pronouns, especially when our patients ask us to. Freedom to express their own pronouns, other issues freely, making sure that that we understand and it's okay. I think there's a big problem with communication when our patients don't feel comfortable telling their whole story. I can lose valuable information, and when our job is to optimize movement to improve quality of life or improve the human experience, I want to know all of your human experience in order to do that. And I don't care what that experience is, because I'm trying to improve your human experience. And knowing all of that and being able to have my patients feel comfortable enough to say that can be really daunting, especially in the healthcare field. There still remains a lot of walls put up. So I hope that we all can appreciate that. So electronic communication is another form of communication, really good for quick communication, but we have to keep it professional. I'm going to talk just professional life here. But one thing about electronic communication is if a good amount of communication is nonverbal language, tone, rates of speech, all of that stuff, we lose a lot of that with written electronic communication. Who's gotten into a fight with someone over text message over some sort of misunderstanding? That my wife does it to me all the time because that was sarcastic. All right, you can't read sarcasm in a text. Probably doesn't help that I say, you're so smart. Like, I probably shouldn't be typing that. No, I said you're so smart. Not yet. Have to edit this. But who else has gotten into an argument over text messages when it's like, that's not what happened? Like, right? So because we lose a lot of context to the conversation. So when we're using electronic communication, hospital systems, skilled nursing facilities, I know some bigger outpatient practices have a communication tab. We have it with our home care where we can text back and forth, but there's a lot of context communication that gets lost in text message. So you have to be careful. We also have to make sure we keep it professional. One of the messaging apps I just saw started including emojis, and I was like, I don't want emojis in the medical conversations. That, like, I don't want. What does this duck mean? I don't know. Is this, what are they saying? So, keeping it professional, and I think there's also going to be some generational divide with electronic communication like that. Our older practitioners are going to be very upset if we use emojis versus our younger professionals, and that's a language that they can decipher quickly. So anyway, messaging patients with unsecure methods is a HIPAA violation. So I can't text my staff that's working right now, how is Nancy? How is this patient who lives in this town? I got to talk to you about that. I cannot write any of that. I text it just back and forth. If I use my secure messaging platform, because there's extra security layers to it, then I can use that. So we have to be really, really careful how we communicate about patients with electronic communication as well. So communication with the healthcare team is really important. Knowing what each member does and what information they can decipher, because each profession does have its own professional jargon. When I talk about somebody's gait, what am I talking about? How they walk. Does every profession know that gait means walk? No. So making sure that we're understanding each role and adjusting our communication too. We'll talk more about that in team model discussion. That's after Thanksgiving. We'll talk about team models. So we want to trust our expertise, but stay within our scope of practice. You as the PTA, and you did physical therapy with your patients, you know more about their physical ability than anybody else in that hospital, anybody else in that SNF, anybody else that is going to come in contact with that patient. But stay within your scope of practice. If you see the patient has trouble talking, it is important for you to recognize that, because that might be a medical emergency right now, or it might be an underlying condition that is coming out now that nobody saw earlier. And sometimes that happens with physical exertion. I have a friend, she had a stroke at the age of, I think she was 20. She has no impairments, residual impairments, until she's fatigued. So when she plays pickup soccer, at the end of her game, her left side of her face starts to droop. After an hour of rest, it's back fine again. But so sometimes those residual symptoms or unique symptoms come out when we're tired, when we're fatigued, and nobody saw it because when the speech therapist was here, patient was fine, but now it's coming out. So our job is to say this person's having trouble speaking. They could not recall, they couldn't do. We could describe it however we can, but it's important for us to make sure we're staying within our scope. This person has dysphagia or aphasia. Well, no, that's not our job to diagnose that. That's even as a physical therapist, that's not my job to say they've got this problem. So staying within your scope of practice, pulling somebody in and say, when I did this exercise, they started exhibiting this symptom. That's good communication. That's staying within your scope of practice. So that's important. But by definition, you as the PTA have to communicate with at least one other member of the healthcare team. Who is that? PT. Great. And even with how often do we communicate with that person, by the way? Yeah, by definition, every 2 weeks, patient reevals monthly. So yes, we are in frequent communication at least. And any other time something comes up, good or bad, we're communicating. So I had a PTA. I have little ego when it comes to patients. I really respect the people I work with, and part of me respecting them is valuing what they have to say. I have a newer PTA. She's been a PTA for a while, but she's newer to our company. She told me I missed something. Josh, this person's balance is way off. I don't care what your numbers said on day one. Their balance is terrible. We need balance goals with this patient. Great. Tell me what you think. So I did these measures. It didn't come up. What are you seeing? When are you seeing it? Okay, I think this test probably works. Do you have any other tests you like? I think this test will be. Hey, that's a great idea. Next time, I'll come tomorrow. I'll do a reevaluation. I'll do those tests, and we'll start writing balance goals in their plan of care so that you as the PTA can start working on balance. Healthy, good communication. You know, Josh, you missed something. I mean, I don't have much of an ego because who does that benefit? I have a healthy ego when it comes to my teaching ability, but my patient wise, I don't care. Tell me whatever. But really good communication. She said, Josh, you made a mistake, right? And that can go wrong. One, she's a professional. She told me in a really nice way. I forget how she phrased it, but yeah, she told me what the problem was, and she also stayed within her scope of practice. I think we need balanced goals because I'm seeing this, and your numbers on the evaluation don't make sense to what I'm seeing now. Great. So that's what trusting your expertise, but staying within your scope of practice is. So we're going to talk about SOAP notes. SOAP notes is the foundation of documentation on daily visits. There's a lot of variety of methods to use for documentation, but SOAP note format is the most common form. And even in our electronic documentation, if we were to step back, it follows a SOAP note format. So I love teaching SOAP notes because it is the foundation for all documentation. And documentation is a form of communication. So why do we document? One, it's a legal record of what the therapist does in a treatment. If you don't record it, it didn't happen. Payment, we wanted to make sure we get paid. So insurances like us, we have to pay, document to say, yes, we need this. It could be research. But another one is communication. To other therapists is the minimum. So even when I just check in with my PTAs, when I do that reeval, I read their notes. I read their notes for the last 3 or 4 visits. How are this person doing? That is communication to me. Even though that PTA is writing about their patient, their visit, they're also communicating to me about what they're doing. But in other settings, medical doctors can read our notes, nurses, case managers, insurances, other professions, on and on and on. when I worked in the hospital, I was shocked that anybody read my notes. But the night nurse thanked me. I never saw the night nurse. She came on at 8 p.m. I left at 5 p.m. She came on at 8. She left at 7 or 8 in the morning. I rolled in at 8:30. I never saw this woman. One day she messaged me, Josh, I just want to say thank you so much for your detailed notes on your patients. When this person needs to go to the bathroom at night, I know I can walk them to the bathroom and I don't have to use the bedside commode or urinal or whatever it might be because of your notes. I can't believe I can't believe I did a good job writing these notes because I hate writing notes. 2, I can't believe anybody's reading it. 3, I can't believe somebody's shift was better because of my note. Like, I was so shocked of all of these things. Yeah, other people are going to be reading our notes, especially working in a multi-collaborative setting like a skilled nurse facility or a hospital. So how do we document? We want to be accurate, specific, but brief. I hate reading notes that go on and on and on. Stop trying to write, the Odyssey about, no, just tell me you got on a boat and you went on a ride. Like, you don't have to tell me this whole big thing. So be brief, clear and legible. If we're handwriting notes, I do have a couple of clinics that still use pencil and paper, pen and paper. It's not pencil. I'm going to read that in just a few things, but still use handwritten notes. So it has to be legible. If we're handwriting, it's got to be legible. If I can't read it, basically can't use it. Professional. Big thing is always date, sometimes time, and sign each note. Electronically, that's done for us. But if it's handwritten, no spaces between lines if it's handwritten. Using black pen if it's handwritten. Anybody know why black pen is used? Not any other, not blue. It's a really stupid reason. Fax machines can't read blue ink. So when we fax our notes to somebody, they can't read them. So we have to use black. So I don't think that's usually a problem anymore, but hey, some places do. If we have an error, we have to have a single solid line through the error because you still have to read the note if it's handwritten. Never blacking out, scribbling out, whiting out, none of that. Single solid line, because then it looks like fraud. If somebody goes back to the chart later, it looks like fraud. And if we can't say, no, that was just this error, well, if I can't read that error, it's fraud. It means underneath this blackout or whiteout, it says the patient fell down the stairs. And there's no way for me to say, no, it doesn't. So it's a single solid line. You have a question?
So what do you do if you do make a mistake? Like redo it on a new piece of paper or something?
Yeah, so if it's a paper chart, what we do is single solid line through the error, and then the next line is we write whatever we're supposed to. Years ago, when I first started my career, I was on pen and paper, handwritten notes. Sad to say, I happened on more than one occasion. Didn't happen often, but it was more than twice. I wrote an entire note in the wrong chart. Wrote about my 3 o'clock patient and my 2 o'clock patient's chart. That entire note, single line throughout the entire thing, little note at the end, wrong patient with my initials on it, and then I write the correct note underneath of that. And then I gotta go back to that chart and write it's terrible when that happens. With electronic documentation, now we click on addendum, wrote wrong narrative for wrong patient, updated narrative is this. So with electronic documentation, we get to do it that way. So the SOAP note, SOAP, each letter stands for something. S stands for subjective. It's what the patient says with their mouth. Sometimes it's patients' family members, especially in pediatrics. My patient that has advanced dementia, I'm relying on information from the family. But most of the time, most patients is what the patient says with their mouth. We hope that we can steer the conversation to be specific and relating it back to their function. So, the first question is always, how are you doing? sun is out, rain, I feel great, I do terrible. Okay, tell me about how you're doing with stairs, because that's one of our big goals. Oh, last time I did stairs, I did great. I went up one step at a time and it was slow, but I did great, way better than before. Great. I get to document that the patient states they did better with stairs, but was slow and one step at a time. Great, I get to write that. And also like, you know, part of the subjective conversation, the communication with our patient is getting enough information. Just writing patient states pain is improving. I need more information than that. So my follow-up questions is, great. On a scale of 0 to 10, what do you think your pain is now? 6. And what do you think it was 2 weeks ago when we started? Or 4. Great. What do you think it was? 6. Great. Patient states that pain in the left hip is 4 out of 10 when walking versus 6 out of 10 last week. Right now, that gives me a lot of information versus just patient states they're improving. All right. Tell me more. All right. So this adjustment tells me a rating, it tells me an activity. Man, that is great. Using semicolon to string multiple statements. So instead of writing my hip is feeling better at night, patient states position covered on the left sideline, I can make it shorter by using a semicolon. Sometimes you need that. For all of our SOAP notes, with the exception of the assessment section, having complete thoughts, but not necessarily complete sentences and grammar. This is something that's a little bit controversial in the textbooks that I use to write this. It does say that, so it's not just my opinion. It does say that. I do have some other practitioners say it's about them. It's hard for me to read notes when it's not written well. It's when it's not written in the correct grammar. All right, I'm not gonna write it for you. I'm just gonna write it because I want to get it done. Anyway. So we have a little example. So if this patient goal increased dorsiflexion range of motion by 4 degrees in 5 days, patient states ankle feels like it's moving a little bit more. All right, any problems with that subjective? Yeah, what more information would you like if we could? Yep. Yeah. So moving a little more, I would say that's positive, right? It means we're on the right track. The question is like, when do you know that? Walking, laying in bed, when you're doing a home exercise program, like when do you notice that it's moving a little bit better? So, all right, quickly, here we have 7 statements. Take us a couple of seconds to read them. What I want you to do is select the number of statements, there's more than one, that you think belong in the subjective section of the SOAP note. Got some answers? What do you guys think?
First one is 3.
Number 3, you think? Okay. Any others? 7, complains of pain. So again, like, I think sometimes all of these will make more sense as we keep learning each section. So if you're a little off right now or you're confused, that's okay. The more when we learn O and A and P, you'll be able to piece them all together. But my big clue for you is information coming from the patient's mouth. Sometimes a family member's mouth, but it's coming from someone's mouth. That's not ours. So, first one, patient complains of pain in left wrist. Where's that coming from? Patient's mouth. Strength in lower extremity within normal limits. That's what WNL is. No, is your patient ever coming in saying my strength is normal? No. This third one, patient not gonna be able to communicate, that's an interesting one. We'll get to in a little bit. Has good rehab potential, tolerated treatment well. States his goal to return to sport ASAP. I think so. Patient states, right? Yeah. And then last one, complains of pain. Yes. So those three, 1, 6, and 7 are all subjective statements. The other ones will be more clear in a little bit. We're not going to do this, but you could edit all of these statements to make them a better subjective statement. So that first one, what are we missing with this first one? We'll just do this first one. We'll do the first one and the last one. What activity? Anything else? Some sort of pain rating. Yeah, good. This last one, I want to pause for a second. Patient states her children drive her crazy. Patient states that her shoulder pain is improving. Patient states she forgets what she has trouble with. Patient states she loves the wand thingy. First of all, what's the wand thingy? It could be like massage gun, or it could be ultrasound. Patients always love wand. Whatever the wand thingy is, the patient will always love it. All right. How would you improve this? You think that you should take out? Yeah. So I think it's important when one of the first things is to be brief. We don't want to have information there that's not helpful. I think eliminating extra sentences. I'm going to talk to my patient for 40 minutes. I'm going to write 2 or 3 sentences in this subjective section. I'm not going to write everything the patient ever said. I'm going to write 2 or 3 good sentences about what they said. So I think that might be the case. Eliminate that first sentence. Yeah. I'll go into that in a little bit. What else? Good idea. Like, so we're connecting with the patient, building rapport. They're telling us that they're driving crazy. Maybe that's not necessarily medical information that the next therapist needs to know. We do have something else. First thing you can do is remove patient states and then add and replace them with semicolons. That makes the note just shorter, just because. So that's a great thought. I think for some I had a specific patient in mind when I wrote this example. Sometimes I think that first sentence should be eliminated. We don't need it. For this patient in particular, it would make sense in the rest of the note if you were to read it. That patient was so high strung, so busy. I'm trying to get information about her shoulder, and she says that it's improving, but she forgets what she has trouble with. She can't really tell me how she knows it's improving. Her kids are driving her. The woman that I wrote this about was I forgot to move that. I forget what she had, some sort of high stress job, CEO, busy attorney level of like busy making decisions. The whole company's riding on her decisions type of a career. She had 3 kids. Her husband was out of town for his own work thing for a week. It was towards the end of the week. And she was my patient, and she just snuck in. I can't believe she only made 1 appointment that week, and she was like, I got to leave soon. I did not get any good information from her. She says her shoulder's improving, but she can't tell me how. She can't tell me why. She can't tell me what about it is improving. She forgets what's wrong with her shoulder. Her kids are driving her crazy. The rest of my note says how stressed the patient is. If you just read patient says that her shoulder pain is improving and she forgets what she has trouble with, that patient's ready for what? She's ready for discharge. Shoulder's better and she can't remember what she has trouble with. She's ready for discharge. This patient was nowhere near ready for discharge, and she was so stressed. She was taking care of business. She was taking care of the house. She couldn't even remember which kid had soccer practice and which kid had ballet. She's putting the world ahead of her own needs. Anybody ever been like that? Right? We've all been like that at some point. The worst thing I could do is to say, great, discharge. The biggest thing this woman needs is a hug. So the rest of my note was talking about how she needs physical therapy despite the lack of subjective complaints because she's so stressed. I know based on my objective measures, we'll talk about that next, that she's not ready yet. And part of her problem is also stress, and we'll talk about that too, right? So that's why, so that patient, kids are driving her crazy, that belongs in subjective. When it's just rapport building and they're complaining just because it was a tough night last night, doesn't belong in the note. You see how there's a subtle difference that's there? Anyway,
Just surprised about how many people complain about this there.
I'm,
It's like astoundingly high.
it's sad, isn't it?
Yeah, I like my kids personally.
Yeah, you want to talk about great kids? Let's talk about my kids. They're the best. Yeah. Anyway, so objective is what the patient says with their body. This includes all of the tests that we do, our vitals measurements, the tests that we do. What were some of the other tests that we talk about doing? That we've talked about this entire semester. We've talked about a bunch of different tests. Timed up and go tests, range of motion. All of that's information coming from the patient's body. The patient's mouth doesn't tell us my shoulder only has 120 degrees. Their shoulder tells us that, right? So, again, when we do the next drill, select the O's. Our job is to say, where's the information coming from? If it's from the mouth, patient's mouth, it goes under subjective. If it's information about their body, it goes under objective. All of our treatment goes under objective section. If it's handwritten, tables make things really easy to read. Including exercises that we perform with our patient belong under objective. Because again, that's what their body's able to perform. And this might be dating myself again. You guys ever watch, especially like little kid shows, or maybe karaoke? Anybody do karaoke? Anybody admit to doing karaoke? So when we do karaoke, we see the words on the screen, and is there a little ball, or is it just change colors along the way? Change colors along the way. You guys know, and I think of some shows that my kids watch where it's a bouncing ball on each word. You guys know what I'm talking about? Our objective section should be similar to the karaoke screen or the bouncing ball when our kids are learning words. Step 1, we did vitals. Step 2, we did girth measurements. Step 3, we did gait assessment. Step 4, we did this exercise. Step 5, we did ice at the end. The whole treatment, if we're going to sing along the next time our patient comes to us and I was on vacation last week, I don't know what you did, or I'm not your primary therapist, they're on vacation, I just got to fill in. The objective section is the bouncing ball of what we did that day. And it's even better if it's in the order that we did it, then it's great. Now I know exactly. But yeah, that's the other way to think of the objective section. It's information coming from the body, and it's just the copying the treatment, everything we did within that treatment. So there's a lot of information. We might have to break it down into categories. Important to keep our thoughts and process organized and clear. Sometimes flow sheets are used. Our text here, do you guys have like a handwritten like set of exercises that you walk around and make sure the patient does and then check them off? How do you do it?
Usually, really depends. Like if they've been in there for months, I'll have them like go into the chart and it'll be updated. Like a comp system.
Yep.
But if they go into like table exercises, first, like yeah.
Okay. All right. Any other common ways to, so you get to use the electronic system to know. So if I'm a patient, I already did my eval, I'm on my 3rd visit. I know some exercise, I don't know some others. You're going to instruct them to me, right? Do you have the computer reading out? Okay, next step is squats, next step is lunges, or do you have something else?
Say like that there's 5 that they're doing that day. I look at their computer and I go over to the gym.
Okay, all right.
And like the weight's kind of there, but then they want me to increase it. They just want me to go over to the computer by like
Good.
6
Perfect. Good. So you're using the electronic systems they have. Sometimes they have, anybody have a paper, like the therapists are documenting on the computer, but there's papers of the exercise? Any? Yeah, you have that? You have that or you use the computer? Okay. Yep, good. Any others? Paper? What's that? Oh, okay, yeah. So sometimes exercises can be used on a piece of paper that stays in it can get scanned into the computer or not, and sometimes that's just easier than typing out each time, especially when we have a lot of patients and only a handful of computers that work. So sometimes we just have to write C flow sheet or C exercise list. So that's what an exercise flow sheet might look like. I have some problems with this one. You know what my big problem with this one is? So we have the dates at the top, April 6th all the way to May 10th. So 4-5 weeks, this person's been coming in, looks like about twice a week for that amount of time. Oh, and then here's the next set, and there's the next set. All right, so we got a lot of data here. Why are we we're doing 10 reps of all these exercises throughout for 5 weeks? What is changing? Nothing. Is the patient getting, just by reading this part, is the patient getting better, worse, or staying the same? Staying the same. If they were getting better, we'd be seeing everything getting progressed. If they're getting worse, we'd be seeing things get regressed. And that's basically what all of this is, right? That patient's never changing anything. So anyway, that's just a little aside. Sorry, that was there. All right, so here's a little example there. All right, next drill. So same group, tell me which statements belong in the O section, objective. Anybody got it? So again, some of these are tough right now just because we haven't learned assessment and plan yet. But for now, these first, the number 2 and number 6. Number 6, definitely, right? That's vitals, documentation of vitals. Number 2, there's a little discrepancies. If I'm doing a strength test, I'm going to document the results of that strength test. Sometimes within normal limit is acceptable for that. So anyway. So you could do more practice if you wanted. But let's skip to assessment. Assessment is what the therapist says with their brain. So this information is now coming from the therapist. We're using data from the subjective and objective from areas, relating it back to goals and problems to answer these 3 big questions. 1, is the patient getting better or worse? How can we tell? 2, do they still need physical therapy? Is there still a problem? And 3, how is your treatment going to improve their overall function? If we can write this information concisely in a manner where someone without your expertise can understand it, it's really important, especially because people that aren't physical therapists and physical therapist assistants are reading our notes. So we want to be able to discuss that. I will also tell you, when I read other practitioners' notes, a lot of the times I don't, if it's a PT or OT, I'll read the whole thing. Nursing, there's a whole bunch of other, when we do team models, other practices where I reading their objective section it's Greek. I have no idea what you're talking about. The assessment, I did this test and it showed that they have this problem. This is where I think we need to go. This is the additional testing we need. This is the recommended treatment plan. I can understand that from the neurologist. I can't understand the neurologist test because I don't have any clue what you're talking about. So the assessment section being written in a manner that people aren't in physical therapy can read it. So we want to make sure that we include information from subjective and objective to support it. We can't just say patient's getting better. You know they're getting better. Patient's subjective complaint is getting better. Patient has 20 degrees more range of motion. Patient, whatever it might be, walked further than we did last time. So make sure it supports it. You can also point out inconsistencies, problems with the treatment, difficulty gathering data, why you didn't perform an aspect of treatment, justified changes. Didn't get to do last 3 exercises because the patient showed up late due to time constraints. I made an error with reading blood pressure, so I was unable to get during exercise blood pressure testing. Anything along those lines. Could not find the tape measure in the clinic that day, so we didn't get to measure swelling. All right, that sucks. Couldn't find it. I'm sure you tried, right? So, any important information that the next therapist would need to do their job, and any other collaboration that goes in with other professionals would go here as well. So again, it's information from the patient's brain. Here's our example, range of motion improving slightly. Increased dorsiflexion range of motion will normalize gait mechanics in order patient to improve function. If I could make this a little bit better, if I was to type that out, I would say exactly what function that is. Going downstairs, walking pain-free, return to sport, like whatever that might be. All right, same thing, select the A's, the assessment statements. All right, any answers yet? What do you got? 3, patient unable to communicate, thus unable to perform. Yeah, we can't ask the patient's pain because the patient can't communicate. Yes, 3, I think it's a great answer. Any other great ones? 5, inability to do strength test because the patient unable to follow commands. Great. Decrease lower extremity strains limits ability to climb stairs. Yeah, what a great statement, right? So, do you have strength? Do you have leg strength to climb stairs? We gotta climb stairs. Gotta make the leg stronger. Yeah, I love that. Yeah, good. See, yep, those are the big ones. Nice. So the plan. I'll also. I want to go back here for 1 second. Just a personal pet peeve. Tolerated treatment well is a commonly used assessment section, but here's the problem with it. 1, does it give the next therapist any additional information? No. 2, does it tell us what the patient's problem is? Does it tell us if we're getting better or worse? Does it give us any real information? That's true. Just because they tolerate us doesn't mean it's going to be tolerated well tomorrow, right? But here's the next thing. Should our patients ever not tolerate the treatment well? What does it mean to not tolerate a treatment well? They got hurt, they got some sort of injury, they got burned by whatever we did. Like, that should never happen. Our patients should always tolerate the treatment well. Like, that's such a silly thing to say. I don't think so. I think plenty of my patients are fatigued, and I think we did a great job. Staying away from fatigue is not necessarily a goal of ours. And I think one of the bigger problems with physical therapy is how much we underdose exercise. If I've got my and the techs here can you know the patients that do it, and sometimes it's the therapist's fault, and sometimes it's the patient's fault. The patients that have done the same exercises 12 visits in a row, they're using the yellow TheraBand for all of their exercise, and they're talking to whoever they're standing next to, just cranking out, like not even paying attention to what they're doing. That person is underdosed in their exercise. We need things to be harder if we're going to make gains. So I think that's a big problem in physical therapy, is being afraid of fatigue. Now, my patients that live alone, I don't want them to be so tired they can't get up the couch. I don't want them to be so tired they can't make their own dinner. Like there's a realm that we have to be reasonable with. And some with our medically fragile patients, we have to be really careful with. My patient with ALS, got to be super careful not to overexert him. But we're still doing exercise. So I think that's a little pet peeve of mine in the physical therapy world, is being too afraid to exert, get tired. But yeah, tolerated treatment well it's just writing words to write words. I don't know what to say. I'll write tolerated treatment well. Gives me no additional information. And if you write that, I'm questioning your ability as a therapist. Like, did you think they weren't going to tolerate it well? Like, grandma with osteoporosis, I had her jump on the trampoline. Now she has 3 fractures. Was not tolerated well. Like, it's so ridiculous. Anyway, I'll stop. We're getting close to the end of class. I don't want to. I'm gonna have a similar tangent on plan too, so just be ready. All right, the first thing: do not just continue PT. All right, it gives me no additional information. If you guys have been working with the patient for the last 2 weeks and now you're on vacation and I have to treat them, if you write continue with PT, it does not tell me how to progress the patient. This patient, this therapist, wrote continue with PT every single visit. Did the patient progress? No. So why are we continuing with PT? What are we going to do for them? We should always have changes that we anticipate making for the next visit. You just spent 20 to 60 minutes with that person. What are you going to change for them next time? Something is always, maybe not always, but something is frequently going to change. If we're not changing something each week at least, I'm questioning if we're actually doing anything beneficial for that patient. So what changes do we anticipate making? What do you plan to remeasure? Those are the big ones, the ones that we definitely should be writing. You just worked with the patient. If you think they're ready for the red TheraBand next time instead of the green, can you please write it? Because if I'm covering for you because you got a flat tire and you're going to be late and I got to cover your 7:30 in the morning patient, I don't know anything about them other than what you wrote in your note. You are the expert on that patient. You just worked on them for 60 minutes, 40 minutes, 20. I don't care. You are the expert. What do you think they're ready for? Adding this exercise, making this exercise harder. What changes? We can also say, what is the therapist or patient going to do prior to the next visit? I'm going to research balance exercise. I'm going to research this, or a patient is going to see orthopedic surgeon for follow-up visit. So that information can be important. Why is that important to write if the patient's going to see ortho for the next visit? Why do we write it down?
Know what you're gonna do with.
Potentially. So everything's in order. And if I'm covering for you and you do a good job, you say increase to red TheraBand on squats. Great. Patient to see ortho before next visit. What's my first question going to be to that patient when they come in? What did doc say? How did that go? And I mean, for my patients in home care, I'm also asking, like, how did you do getting out of the house? How did you getting in and out of the car? Was it a long walk from the parking lot to the office? Like, I'm asking more data, but in the outpatient world, it's what did the doc say? are you healing? Are you not? Like, what did the x-rays say? Do we have different weight bearing restriction? Like I want that information. So if you write that, it's so important to write that because now I know what to ask about the next time. If you don't write that and I just say, how's your leg? Great, let's keep going. I'm missing a ton of important information. What will the therapist do prior to next visit is important as well. So here's our running note plan, reassess dorsiflexion range of motion, progress stretching to weight bearing if patient can tolerate. So that is a little different than tolerated well. So, although if I were to write it again, I'd probably delete that. Anyway, all right. Select the P's. Select the statements that belong in P. All right, any answers? 2, I think 2 is a good one. How do we make 2 just a little bit better? What weight? Yeah, yeah. I think if you put increased weight, I would, at least I know what direction we're going into, but if you said, if you guys text, no, you see patients, day 1, they did this exercise, and they said, we can bump up a lot of weight next time. We can go, we're doing 3 pounds, we can definitely go up to 5 or 8 pounds. Like we're really close to that. So yeah, you are the expert. Your gut feeling, your clinical judgment matters. So let's tell me the exact weight and I'll be able to do it. Any others? 5, reassess swelling and girth measurements. Yep. What are we going to do next visit? Anything else? We'll be given home exercise program on shoulder. Yeah, those are the 3. Good. So writing in a professional manner with appropriate terminology is important. Most notes are written in third person perspective. Patient is referred to as patient. The therapist, you, is referred to therapist or PTA. I started getting away from that. I started writing my notes. When I write about Bob, I write Bob says. It's just a little bit more personal. And I stopped saying, referring to myself as third person. I start saying I. Nobody's told me I can't do that yet. But I think when our care should be patient-centric, I think our documentation should also be patient-centric. Let's stop calling it patient says. Let's say Bob says. Like I do think that can be important. Maybe it's not. I don't know. Especially when none of my patients are named Bob and I keep writing Bob says. Maybe that's a problem. But making sure that you're within your scope of practice when writing the note and making changes. If the patient has all signs of a torn ACL and not just a knee sprain, your job is to not diagnose torn ACL. But in your note, you can talk about knee buckled 3 times when performing step down exercise. Visually, it looked like tibia shifted anteriorly when that knee did buckle. Assessment section, questioning knee stability, are ligaments intact? Plan, discuss with therapist on additional evaluation for ligamentous integrity. You know that ACL is torn. You just know it is. It's not your job, right? So there's some art to that. Also, scope of practice, just like my therapist did, balance was not in the scope of practice. She couldn't just write perform balance exercises next time. It has to be within the plan of care. And if it's in the plan of care, she can then start doing it and then she can operate within that plan of care. So she can't write perform balance exercise next time if it's not in that plan of care. So if you wanted to, here's a patient, we could patient experience that we could write a SOAP note for. Here's some others, but you do not have to. Not a bad exercise if you want to get really good at writing SOAP notes. In this class, what it will look like is, I mean, we have written exams. It'll actually be a lot like the drills we did. What part of the SOAP note does this information belong into, S, O, A, or P? Things like that. I think that's probably more realistic. But if you wanted to get practice with writing SOAP notes, feel free. All right, exam next week. I will open it for 8 a.m. on Saturday, and it has to be completed by midnight on Wednesday night. Okay. Oh, brochure is due. That's a good question. Let me just look at the calendar. So next week, Thanksgiving, we are covering team models on November 30th. So brochures due 1 week later, the 7th. So you got plenty of time to do it. How many people are already done with it? All right, good. But I'll make it December 7th for that.
I rushed it. I was nervous.
So if it's done and you're happy with it, you're done. I apologize for not making that more clear. No, it's due the 7th because I haven't talked about team models, but you have enough information to do that assignment, and seeing that we didn't have class last week, it's a good, just get it done. I'll open it for Saturday at 8. If you an early bird, you want me to make it for earlier? 6 a.m. I'll do by Wednesday at midnight. Yeah. Same format, take it on your own. I'll put respondents on it, and yeah, if any issues, let me know. I think that's been working out okay. Yeah. I do have a practice test, yes, and that is up. I just made it live today, so you can feel free to do that. It's just like the rest of them, worth like 2% of your grade. I think 5 or 6 attempts to do it, something like that. So yeah, there's a practice test. I put that up there.
It's great.
Yeah. Yeah, it's part of your homework assignments, so yeah. Yeah, do as many times until you're happy with the grade, yeah. Yep. All right, anything else? The last 3 things we talked about,
6, 9, 10, and 11.
yes. Yeah, integumentary, financing, healthcare, integumentary, and communication that we covered today. Nope, just these 3. The final exam will be cumulative, including the 2 new topics, but it'll be cumulative. Okay?
So final exam be so be home or
Final exam will also be from home, and that'll be on the 14th. Yeah. Okay? All right.
I know, right?
The class